Good morning, one and all. Myself, Dr KIRUBHALANI Selvan, second year PG resident of Safdarjung Hospital, here to present the case titled the hippel crite. So, why have we named it so? We'll know it in the following slides. A 17-year-old female presented to the IOPD with complaints of right eye diminution of vision for 3 months, which was gradual, progressive, painless. She gave no history of preceding trauma or surgery in the right eye. However, there was history of sudden onset diminution of vision in the left eye 2 years back. She was shown elsewhere, operated for cataract, and she has poor post-op vision gain since then. Past history, there was no history of ocular trauma or use of spectacles. She underwent uneventful cholecystectomy in the year 2023 for abdominal pain. Her perinatal history was within normal limits. However, her father has low vision in the right eye since 30 years of age. He was not available for examination, nor records were available. On ocular examination, right eye visual acuity was 636 with normal anterior segment, whereas in the left eye she was denying PL with anterior segment showing seclusion pupillae with iris bombay and PCIOL, and there was no view of the posterior segment in the left eye. Posterior segment photo of the right eye shows large elevated orangish vascular lesion with dilated tortuous artery and draining vein in the superior quadrant with multiple small orange lesions arising from retinal vasels with surrounding exudation in the temporal quadrant with peripapillary massive subretinal exudation and hard exudates at the macula. Retrospectively, we asked history of headache, seizures and generalized body weakness, which was all negative. She had no history of hearing difficulties, dysuria or hematuria, and she gave no history of family history of sudden deaths or malignancy. A provisional diagnosis of right eye multiple retinal capillary hemangiomas with macular edema was made and left absolute eye status post cataract surgery. We suspected von Hippel-Lindau disease in this patient as it was an young age at onset. She had a bilateral disease with multiple retinal capillary hemangiomas and unknown cause of vision loss in the father. So we planned OCT macula and FFA of the right eye and USG B scan of the left eye. USG whole abdomen and MRI brain was done to rule out other VHL related tumors, and family screening was also planned. OCT macula of the right eye shows subretinal fluid with hard exudates at the fovea, and FFA of the right eye shows dilated tortuous retinal vessels with hyperfluorescent lesion in the superior quadrant showing leakage. And B scan of the left eye shows disorganized globe structure suggestive of atrophic bulbi. On systemic radiological imaging, it was normal. However, on MRI brain and spine, we found RD with CD with retinal tumors in the left eye, which was an absolute eye. And Puton audiometry was within normal limits and BP monitoring was within normal limits. So we started the patient prophylactically on oral steroids and atorvastatin, followed by right eye intravitreal ranibizumab. So OCT, post which there was resolution of SRF and decrease in exudates and visual acuity improved from 636 to 69. Next step, we planned for laser photocoagulation of the retinal hemangiomas with single spot double frequency NDR laser, with which the smaller lesions were blanched with laser. However, there was poor uptake of laser in the superior quadrant, so a row of spots was created around the lesion to limit the exudation from extending onto the macula, and multiple sittings of laser were planned. We noted recurrence of SRF at 1 month post-injection with fluid extending up to the fovea, and the visual acuity dropped from 6.9 to 6.60. So what do we do next? Clinically, a fibrous band over the large lesion with traction on surrounding retina was noted. So, as there was a poor uptake of laser over the lesion, as well as there was a risk of crunch phenomenon with repeat injection, we decided to refer the patient for a second opinion to RPC AIIMS New Delhi, where she received repeat intravitreal ranibizumab and triamcinolone acetate. On follow-up, we are planning to supplement laser 1 month post-injection with annual monitoring for systemic tumors and gene counseling for VHL mutation, and family screening is also planned. So we conclude by saying that VHL syndrome presents heterogeneously in different patients, with retinal capillary hemangioma as the presenting feature in 50% of the VHL patients. And it is essential for an ophthalmologist to diagnose retinal capillary hemangiomas and refer the patient for systemic screening. Lifetime screening for VHL related tumors is essential, which can be mitigated by gene testing. Thank you.
I think these tumors are obviously very difficult to manage, and I think with the fibrous element, I think the treatment which was postulated is absolutely right. But then if the traction increases, then surgery is the only inevitable part, but then that they also really don't this thing. One other aspect is cryo, which could be used in these cases. Anyways, I think he's got a long course ahead, and I think it only thing that I would change in this or would think about was that probably do the laser in the other parts first and then go to the angioma, and would not try to hit the angioma directly with laser.
Yes.
I don't think such a large angioma can really go down with a focal laser or anything. Cryo maybe yes, but then again with that fibrous element, it becomes a little tricky. So yeah, but I think slow and steady would work in this.
So that's why we just hit the laser. We did not directly hit the tumor. We just placed 2 rows of laser around the hemangioma, so that the exudation doesn't extend to the macular and worsen the visual acuity.
Yeah. And then there are surgery where they're doing basically they do ligation and everything, which can also be done. But then given the one eye status, I think I would be very, very cautious in going very aggressive, because ultimately even surgical results don't sometimes prove to be very, very great.
इन नाम लिखा हिप्पल क्राइट, क्या मतलब है?
So the hypocrite in our case is one hippel window disease. So hypocrite को
So
hippel
पहले diagnosis बता देती तो फिर
चलो, थैंक यू.